Having understood the mechanism of action of the d-Tubocurarine, let us move on to the pharmacodynamic actions mediated by d-Tubocurarine. So it can cause skeletal muscle paralysis, it will cause histamine release, it can cause ganglionic blockade as well as cardiac muscarinic receptor blockade. It can also have a cardiovascular effect as well as respiratory effect and also GI effects. So coming to the skeletal muscle paralysis, on IV injection of d-Tubocurarine, it leads to motor weakness leading to progressive muscle paralysis or flaccid paralysis. So first, the muscles which will going to be affected, or the fast moving smaller muscles are affected first, like eye, jaws, toes and the larynx, and second will be the larger muscles like limb, trunk, and finally there will be paralysis of the intercostal muscles and the diaphragm. And the recovery will take place in the opposite direction. The first muscle to recover is the diaphragm and the intercostal muscle, and last muscle to get recovered from the skeletal muscle blockers will be your smaller muscles. So secondly, it also lead to histamine release by activating the mast cells. So especially the benzyl isoquinoline derivatives like d-Tubocurarine will increase the chance of release of histamine, and lesser release is seen with mivacurium, doxacurium and atracurium, and least by the pancuranium, pipacurium, rocuranium and vecuranium because they belongs to the steroidal derivatives. And next, coming to the ganglionic blockade. So this d-Tubocurarine can cause partial blockade of the autonomic ganglion, and this can lead to hypotension. And least blockade will be seen with doxacurium, mivacurium, cisatracurium, and steroidal derivative do not block the autonomic ganglion. And only exception is the pancuranium. Pancuranium has got vagolytic action because of the M2 blockade in the heart, leading to tachycardia. Cardiovascular effect due to the histamine release, it can cause hypotension, and also hypotension can be related with the partial ganglionic blockade produced by d-Tubocurarine. And also pancuranium causes tachycardia, and others drugs have got good CV stability. On the respiratory system, due to the release of histamine, it can lead to bronchospasm. On the GI, there will be decrease in the tone as well as motility in the GIT, and recovery is followed by constipation. So coming to the pharmacokinetic parameters of the non-depolarizing blockers, being a quaternary compound and they are polar in nature and they get ionized at physiological pH. Because of this nature, they cannot be used orally and it has to be given through intravenous route. And their potency, onset, duration of action will going to differ with respect to the drugs. Larger acting or the longer acting agents have got more potent, and with the low dose you can expect the more potency. But the problem is at the low dose there'll be delay in the onset of the action except for the pipacuranium, which is the longer acting drug. And route of elimination is correlated with the duration of action. So majority of the drugs will get eliminated through the kidney, especially the longer acting drugs. And the liver elimination will be followed by intermediate to short acting duration of action drugs, and there will be inactivation of the inactivation by the plasma cholinesterases for the shorter acting drugs like mivacurium. Because of the rapid inactivation by the plasma cholinesterase, mivacurium is the shortest acting non-depolarizing blocker. And please note that in case of renal failure, plasma cholinesterase level may come down and the duration of action of mivacurium may be prolonged. And very important thing to remember is the Hoffman's elimination, and isoquinoline derivative which is eliminated spontaneously by Hoffman's elimination, which is also called as non-enzymatic elimination, is your drug atracurium and cisatracurium. Here there is a rupture of the ester containing bridge joining the two isoquinoline moiety. So this is called as non-enzymatic reaction. Usually for other drugs, the enzyme is responsible for metabolism or breakdown of the drug. Here in Hoffman's elimination, there is a rupture of ester containing bridge joining the two isoquinoline moiety. So there is no involvement of the enzyme. That's why they are called as non-enzymatic elimination. So this property has been seen with the drugs like atracurium and cisatracurium. The main metabolite of atracurium will be your laudanacin, which has got no neuromuscular blocking activity, but it crosses the blood-brain barrier, and the disadvantage of laudanacin is it can cause seizures. On the other hand, cis-atracurium being a congener of atracurium, which is very safer, and the advantage over atracurium is cis-atracurium has got less laudanocin production as well as less histamine release. And you need to remember two important preferred agents. In case of renal failure, you need to go with rocuronium because rocuronium undergoes hepatic elimination. Whereas in case of hepatic dysfunction, you need to the preferred group of drugs. Preferred skeletal muscle relaxants will be your atracurium and cis-atracurium, which undergoes Hoffman's elimination. And also, these non-depolarizing blockers undergo smaller apparent volume of distribution except atracurium. None of them will cross blood-brain barrier and there is no CNS toxicity associated with it. And also please remember, they do not cross the placenta and these drugs can be used during cesarean section without affecting the newborn. So coming to the clinical uses of non-depolarizing blockers. They can be used as adjuvant in case of general anesthesia to prevent trauma during electroconvulsive therapy, in case of spastic conditions like tetanus, status epilepticus, which are not controlled by the diazepam or the other group of drugs. And fourth condition, to control ventilation, especially to eliminate the chest wall resistance in case of the obstructive conditions. So as an adjunct to general anesthesia, these skeletal muscle relaxants can be used for abdominal, thoracic surgery and endotracheal intubation, and also to counteract the laryngospasm during barbiturate anesthesia, and also to prevent the reflex muscle contraction during any surgeries. So selection will be based on onset and the duration of blockade and depends on the hepatic as well as renal and hemodynamic status. And for the brief procedure, you can go with the succinylcholine or mivacurium because of their rapid metabolism by the true plasma choline esterases, And this, for brief procedures, you can go with the shorter acting drugs like succinylcholine and mivacurium for endotracheal intubation, laryngoscopy, and bronchospasm. And mivacurium being the shortest drug, it does not need any reversal agent like neostigmine, which has to be used for longer acting non-depolarizing blockers. In case of renal or hepatic insufficiency, you can go with drugs like atracurium, cis-atracurium can be preferred because of their Hoffman's elimination. And also, in case of renal compromised patient, you can go with rocuronium, which undergoes metabolism through liver. And in routine practices, we use pancuronium as a non-depolarizing skeletal muscle relaxant. Coming to the adverse effect profile of the non-depolarizing blockers. So non-depolarizing blockers has got main adverse effect is the skeletal muscle paralysis and the histamine release. Skeletal muscle paralysis lead to hypoxia, difficulty in breathing and respiratory paralysis, whereas histamine release will lead to hypotension and bronchospasm. And further ganglionic blockade will cause hypotension, and also the vagolytic action will cause tachycardia, especially with the pancuronium. And please remember, the treatment for this skeletal muscle paralysis or hypoxia will be your artificial respiration. You need to reverse the skeletal muscle relaxant blocking activity by giving neostigmine, which is anticholinesterase. But the problem with neostigmine is you need to be very, very careful. Along with activating the NM receptors, it also activates the muscarinic receptors, which further it can lead to bronchospasm, hypotension, and bradycardia. So add-on drug which you should remember is you can add sympathomimetic drug like adrenaline to overcome the hypotension and bronchospasm, and also atropine and glycopyrrolate, which are the anti-muscarinic drugs, can be used to counteract the muscarinic symptoms produced by neostigmine. Histamine can be used for counteracting the histamine mediated activities like hypotension and bronchospasm. So coming to the blockade reversal of the non-depolarizing blockers. So how do you reverse the actions of the d-Tubocurarine? So drug of choice will be your neostigmine or pyridostigmine, which antagonizes or reverses the non-depolarizing neuromuscular blockade. Basically, it inhibits the true acetylcholinesterases in the synaptic cleft and also the direct nicotinic action on the motor end plate. So when to use this? These are used whenever you use a longer acting or intermediate acting neuromuscular blockers and to reverse the neuromuscular blockade activity by the longer acting non-depolarizing blockers. The special drug which you need to remember here is the Sugammadex. Sugammadex is a drug which reverses the neuromuscular blockade, especially the steroidal group of neuromuscular blockers, with example with the rocuronium and vecuronium. To reverse the rocuronium and the vecuronium blockade, you can use the Sugammadex, especially for the steroidal groups. And coming to the special points with respect to the non-depolarizing blockers, one should remember that anticholinesterase agents like neostigmine, pyridostigmine will have an antagonistic action to the non-depolarizing neuromuscular blockers. Hypothermia can enhance the depolarizing action of the acetylcholine, and it will going to antagonize the actions of the neuromuscular blockers. And also the Burns upper motor neuron diseases requires larger doses of the blockers because of their proliferation of extrajunctional receptors. And the inhalational general anesthetic like isoflurane, halothane can decrease the sensitivity of postjunctional membrane to depolarization and act as synergistically with the non-depolarizing blockers. Basically, isoflurane and halothane will enhance or augment the non-depolarizing blockade actions. So aminoglycoside group of drugs like streptomycin, gentamicin, tobramycin will produce neuromuscular blocking action in spite of other side effects like the ototoxicity and nephrotoxicity. So basically, by decreasing the acetylcholine release from preganglionic terminal by blocking the P type of calcium channels. So therefore, aminoglycosides will also augment the neuromuscular blockade action. Other drugs which follows the same characteristic action is polymyxin B, clindamycin and lincomycin. Even tetracycline group will produce NM blockade by chelating the calcium ions. Apart from that, the larger doses of the lignocaine or the local anesthetic will going to cause neuromuscular blockade which has got synergistic action with the non-depolarizing blockers. And also the drugs like quinidine, propranolol, calcium channel blockers like diltiazem and digitalis, diuretics, chloroquine has got synergistic action. But these drugs are not in therapeutically used nowadays, so not have any clinical use along with neuromuscular blockers. So myasthenia gravis is a condition where there is antibody directed against the NM receptor, and this condition will going to markedly augment the non-depolarizing neuromuscular blockade action by the d-Tubocurarine. So basically, the general anesthetic like isoflurane, halothane, aminoglycosides, tetracyclines, quinidine, local anesthetic, the calcium channel blockers will going to augment the non-depolarizing blockers or will augment the d-Tubocurarine activity. So coming to the summary. So summary, and from the previous session as well as from this session, we have learnt about the definition of skeletal muscle relaxant. We understood about the neuromuscular junction physiology and function. We also know the types of skeletal muscle relaxant, and we mainly completed the non-depolarizing skeletal muscle relaxant from peripherally acting muscle relaxant. Mechanism of action, clinical uses of the skeletal non-depolarizing skeletal muscle relaxant, adverse effect of the d-Tubocurarine, and the summary. The bonus concept review will be your trainer 4 response. So what do you understand by trainer 4? Whenever a muscle is activated by the electrical impulses, simultaneously if you give a 4 electrical impulses, what will happen? There will be twitches in the muscle take place. These 4 twitches without any drug, a normal response will be without any drug. If you activate the electrical impulses, you can stimulate the nerves. The common nerve which will be used for stimulation is the ulnar nerve stimulation, which will lead to generation of the 4 twitches. These 4 twitches will be occurring within 1.5 to 2 seconds, and the duration between the twitches will be of 0.5 seconds. So this is the strength of the or magnitude of the contraction which will take place for the electrical stimulus which will going to administer through the electrodes onto the ulnar nerve. And adductor pollicis muscle will going to contract, and there will be flexion, and there will be twitches which will be occurring in the thumb. So this will be named as T1, T2, T3 and T4 twitches. So whenever you give a non-depolarizing blockers, what happens is d-Tubocurarine, there is a fade phenomenon which will occur. This train of 4 impulses will fade off. The reason being the twitches will going to decrease. So how do you calculate the ratio into? So the ratio, the train of 4 ratio can be calculated by the magnitude of T4 divided by magnitude of T1. For normal response without any drugs, it will be of 1. And for d-Tubocurarine, for example, if it has got 100% response and the T4, that is the 4 twitches, if you got the response of the 30%, what will be the train of 4 ratio? The train of 4 ratio will be T4 divided by T1. T1, if you consider it as the 100%, and T4 it as the 30%. So 30 divided by 100, that will be your 0.3. So 0.3 will be your train of ratio response. So this train of ratio response will going to help you in terms of detecting the clinical use or clinical actions which are mediated by d-Tubocurarine. So please remember, if you find this graph in the explanation in case of the exams or in the form of MCQs, you need to pick, they may ask which drug is responsible for producing this type of response or a fade response. It will be with respect to the non-depolarizing blockers, that is the d-Tubocurarine. So this was your bonus concept review. To answer the questions which were asked in the previous session, so let us answer these questions. So which ion influx at nerve terminal releases acetylcholine into synaptic cleft? So the increased calcium trigger or calcium entry will going to increase the release of calcium into the synaptic cleft. So ion influx at the motor end plate of postsynaptic membrane, which leading to impulse generation, that is which is the ion which is responsible for depolarization. It is a sodium ion. So for both the impulse to generate and depolarization to occur, sodium ion should be present, sodium channel should be activated. So SMR, skeletal muscle relaxant, blocking the NM receptor at postsynaptic membrane will be your non-depolarizing blocker, that is d-Tubocurarine. And which drug undergoes Hoffman's elimination? It is your atracurium and cisatracurium. The non-depolarizing blocker action which can be reversed or surmounted by neostigmine. So why hypotension bronchospasm occurs following SMR? Due to the histamine release as well as the ganglionic blockade. In the renal dysfunction, the non-depolarizing blocker which is preferred will be your rocuronium because it undergoes hepatic elimination. And in case of hepatic dysfunction, which non-depolarizing blockers are preferred? It is your atracurium and cisatracurium because it undergoes Hoffman's elimination. Shortest acting depolarizing blocker will be your gantacurium and mevacurium, and longest acting blockers will be your doxacurium, metacurine, pancuronium, and pipacuronium. And steroidal drugs derivatives which belongs to non-depolarizing blockers will be your pancuronium, pipacuronium, vecuronium, and rocuronium, which will be devoid of the ganglionic blockade action. The three drugs which can augment or potentiate the non-depolarizing blocker will be your aminoglycosides, allothane, isoflurane, calcium channel blockers, and tetracyclines. So this was all about the non-depolarizing skeletal muscle relaxants. Thank you. If you find this video useful, please do subscribe to my channel, I Love Pharmacology, for more updates on pharmacology. Thank you.